Tonight we're going to hear from a couple of our local talents. First, we're going to hear from Dr. Adam Law. He's a physician in town. He's an endocrinologist, which means he studies the impacts of hormones. And he was moved a number of years ago to co-found an organization with some other local leaders called Physicians, Scientists, and Engineers for Healthy Energy. And that organization has a great web presence. It's committed to empowering citizens and policymakers by organizing and supplying objective, evidence-based information. So with that, I would like to introduce Adam, who's going to talk to us about what we know and what we don't know.
Thank you very much, Alan, for that introduction, and for you and for Ken and other members of FLEAST for organizing this event today. We all appreciate it greatly. Before I give a talk, I should first of all take some time just to say that there are no conflicts here. I am not on a speakers bureau for any energy corporation, nor for Big Pharma. I have one small disclosure, which is that I was handed this nice gift by Ellen for giving this talk today. So this is my only disclosure that I'm going to give during this talk. So I'm going to talk to you today about what we know about the health impacts of high-volume horizontal hydraulic fracturing on communities, on people, and later you will hear the effects upon animals as sentinels. What I will say in shorthand, the word fracking to me is operationally defined as the whole process from the moment the pad becomes cleared to the moment when the well is capped at the end. So I'm using the word fracking not in a colloquial sense, but actually in a technical sense. Whoops, get used to this in a second. So I'm going to start with the biggest picture, and this is from the New England Journal of Medicine just last week. It's a comment from a foremost expert in epidemiology on climate and on globalization. He finishes his article saying, "For populations to live sustainably and with good long-term health, the health sector must work with other sectors in reshaping how human societies plan, build, move, produce, consume, share, and generate energy." That's what we're talking about today. Physicians, healthcare providers, administrators, public health experts have been left out. So, what are the health concerns? We're concerned, and I've put in red here, something which is not talked about enough: climate change. Climate change is the big health issue that's coming up in the next 20 to 30 years. Air pollution, water pollution, soil pollution, and then, very important, other social and psychological and economic issues: noise, light pollution, STDs, traffic accidents, and vulnerable populations. We all are aware that what we put in the ground consists of large amounts of water, which is called slick water because it's had chemicals added to it, 5 to 10 million gallons, and that the chemicals which are added and the sand which are added can all be hazardous to health. We do not know, because of the 2005 Energy Policy Act, all of the ingredients that go into each well. The industry has published on Frac Focus for each well some of the ingredients going in, but we don't know what's missing. We've had to basically guess what the ingredients are. In this paper from Theo Coburn's group, they looked at 944 products from from MSDSs, from data sheets, and in the end, they boiled them down to 355 unique chemicals. And then they looked in the nervous system and found that many of these chemicals are involved in different kinds of diseases. As you can see from the chart here, skin, eyes, respiratory diseases in 75% in the nervous system, and the endocrine system up to 37%. We also know that what comes out of the ground is dangerous. There are salts, because this fluid originated under the ground in ancient seas. Heavy metals, endocrine disruptors such as arsenic and cadmium, and naturally occurring radioactive materials. In epidemiology, we talk about exposure pathways. This is a technical term. A completed exposure pathway is when you have all 5 of these in existence: a source of contamination, an environmental media and transport mechanism, for example, groundwater or air, a point of exposure, a well, a route of exposure, which is usually at the level of the individual, whether it's inhaled or whether it comes through the skin, and a receptor population, which is those of us who are living in communities close by. I'm not going to go through all of the exposure literature because it's not epidemiological as such. It more belongs to risk assessment, but it's a necessary prerequisite before we do these studies. We know that these wells fail. From this study from wells which were offshore, you can see that, as wells age, they fail some more. PSE has looked at the publicly available data in Pennsylvania, and as you can see from 2010, 11, and 12, the failure rate is between 6 and 8.9%. These wells are going to leak. They're going to leak into water, they're going to leak into air, and that's something to remember. We know that the groundwater can be contaminated. This study, which was extremely well performed in Pavilion, Wyoming, showed that the groundwater there was contaminated with a large number of different chemicals, all of which appear to arise from fracking. And at the moment, because it's an EPA study, it's having to go through a review, and the review is really heavily weighted against essentially validating this. But if anybody's had a chance to read it, it's really a remarkably good document. We know that what we're trying to get out of the ground, methane leaks, and we talked about flaming faucets. This is the scientific data which says the same thing. This was done by Jackson's group at Duke, and where they looked at water wells and their proximity to drilling sites, both with conventional vertical wells and horizontal wells in Pennsylvania and New York. And as you can see, the closer the well is to, the gas well is to the site of the drinking water or the water well, the higher levels of methane there are. And we can see that this is a hazardous level here, and many of these data points are really extremely high. At this point, we're trying to figure out what methane does in terms of its direct health abnormalities, but remember, a fixed percentage of what's coming out of the ground contains VOCs and other chemicals as well, which we know are toxic. So when you see methane, read other toxic emissions. So what I want to do is talk about epidemiology. This is prior to epidemiology. This is the sorts of studies that we've had already. This is about exposure assessment. There are indirect methods and direct methods. The indirect methods include questionnaires, diaries, environmental modeling, this goes into computer models, or direct methods where you're measuring things in people's bodies, chemicals, and then you're doing physiologically based pharmacokinetics and dose modeling and toxicology. This is the sort of thing which we are looking at, particularly at the moment with the EPA. We're looking at this sort of approach. And then there's risk assessment, which is another standard method, which is not an epidemiological method per se, but which is used by epidemiologists prior to doing the sorts of studies that they do. First of all, you collect the data, you do a toxicity assessment and an exposure assessment, and then you come up with a number, which is the risk to the population, and you look at what the cancer risk is, you look at what the non-cancer hazard quotient is, you say what the uncertainties, and you summarize the risk information. And there is a study like this. This is actually by Mackenzie, but you may know one of her co-workers, who is Professor Adgate, who was actually one of the 3 reviewers of the SGICE, who was invited in by Nirav Shah to review it. This is a human health risk assessment. They measured the air emissions close to and distant to areas of hydraulic fracturing in Colorado, and then looked at the individual VOCs, or volatile organic compounds, and looked up in what their risk would be at that concentration to health. And what you can see is that with their data, they come out with this kind of endpoint with hazard indices, with health endpoint. This is non-cancer health endpoints. What they do is they look at all the different measurements of VOCs which affect the nervous system. Each of them has a health quotient. They add them up, and you get a health index. And a level of 1 is what it would be if there was no contamination. And you can see that in this preliminary study that there really are increased endpoint risks to the nervous system, to the lungs, and to the blood system of the body. So let's get to epidemiology. Epidemiology is the basic science of public health. It's a study of the distribution of health and disease in the population and of the determinants of this distribution. We're looking at a subsection of environmental epidemiology, the effect of environmental exposures on health and disease in the population, and there's a subsection of this which is called energy epidemiology. There are 3 different types of designs, and I'm going to belabor this point because these studies have not been done. There's descriptive, analytic, and experimental. So here are the existing publications, and when you came in today, you were given 2 sets of sheets which were provided by PSE, and they refer to all of these studies. If you want their references or if you want to look them up, they're all on our website, at the PSE website, so I'm not going to go into detail. What I want you to look at is this column here, human environmental epidemiology, and the lack of checks all the way down here. These are health impact studies. This is epidemiology. The only exception, we're going to have a presentation by Michelle and Robert just a little later, which really truly is one of the first published descriptive epidemiology study. So I'm not going to show their data, I'll let them do it. Descriptive epidemiology is about people, places, and time. There's a very interesting ongoing study called the Southwest Pennsylvania Environmental Health Project, which is a clinic which has been set up in Washington County. And in Washington County, they're seeing people, they're trying to encourage the community who are affected by this sweet spot of hydraulic fracturing to see what kind of problems they're coming with. It is both a service to the community, but it also serves the purpose of research and helping us describe the syndromes that we see. So these are the sorts of studies that we want to see. This is analytic epidemiology, which is observational. This is not the sort of thing you have in a drug trial. This is all observational. And there are a variety of different study designs. I can't show you any in our area because they don't exist. But here's an example of an ecological design, which is to do with populations. The Geisinger study, which I'll tell you about, is going to look at this. This concerns or maps male HIV prevalence and male circumcision in an area of Africa. In white, you can see uncircumcised icons, and in black, circumcised, and you can see in the background the prevalence of HIV. There are problems with this kind of data. There's something called an ecological fallacy. It's easy to jump to conclusions too quickly, but we don't even have this yet in the studies that have been done on fracking. Whoops. And I'll just quickly whiz through some of the other types of designs we've got. We have cross-sectional studies. These are done in one point of time. You take a population, you look at people who are exposed and not exposed, and then you look at cases and non-cases. It can only tell you about prevalence. It can't tell you about incidence. It's great for finding associations. It's lousy for defining causality. Case control studies, which are similar, where you find cases and controls in a community, and you then see whether or not they've been exposed or not exposed, and you figure out what the odds ratios are. Again, a very powerful and very quick sort of study to do, doesn't cost too much. We need this kind of study to find out the associations. Cohort is a study which can either be prospective or historic. You look at a population at the beginning, and then you see over time whether those people who are exposed or not exposed in that community develop cases or do not develop cases of the illness. Again, this is not an experimental procedure. People are not being randomized. This is looking at a community and looking forward. The Framingham study of cardiovascular disease is a classic example of this. Historic or retrospective is very similar, except you start with the cases and the controls, and you look back at time and see if they've been exposed or not. And finally, we have experimental trials. This is what we see as the sort of the most expensive, the most time-consuming, but the best for finding causality. In medicine, randomized controlled trials for drugs is an example. In environmental epidemiology, community trials are the methodology where you have one community that's exposed and one isn't, say to fluoridization. There are experimental designs where you can't have a control like that, where you look at a community, you do all sorts of biometrics before the pollution comes in, and then you look at the incidence of all kinds of diseases in that community, and then when the insult comes in, you look at it again and you see how it changes, and that is an example of an experimental community design. So, 3 studies are in the New York State limelight, and I was asked to talk a little bit about these because we understood that Nirav Shah, who is a physician and a public health, very well trained in public health, he is the Commissioner for Health at the Department of Health and is probably the only person with a health background who's been asked anywhere to make important judgments on this policy decision. If he goes ahead, he knows what we know now, that there are no studies of public health here in the environmental impact statement. I've just shown it to you. He knows it. So if he says that it's fine, and it does show it, he's going to have to live with a lot of cognitive dissonance. So the EPA is doing a study in which they're looking at drinking water resources, and they're looking at factors that might affect the drinking water from fracking. They've got a progress report that just came out in December. 31 members of this committee, none of them are physicians, none of them are healthcare providers. There is not an MPH amongst them. Many of them work in the fossil fuel industry and are engineers, brilliant people, but their whole careers are vested in fossil fuels. There are 7 who work from industry, big pharma, or from the energy industry, and a number of consultants. You can make your own conclusions from that. So they're looking at 5 stages of the water cycle: water acquisition, chemical mixing, well injection, flow back and produced water, and wastewater treatment and disposal. And they're doing studies which they call fundamental research studies at each stage of this. And then when you look at the sorts of projects they're doing, I'm not going to go into detail, but you can see they're looking at literature review, service company analysis, well file review, frac focus. Do you remember frac focus? That's the resource or database from the industry. You can also see that with the flow back and produce water, again, literature review, spills analysis, etc. Do you see any of the study designs I've just talked about? Is this a health impact study? No, it isn't. It's just like the environmental impact study in New York. It's got nothing to do with health impact. So that's 1 out of 3 we can disqualify as being relevant. They're looking at 5 different places, but they're not looking at health outcomes. And so, not a health impact study. The panel is biased. The oil and gas industry and pharmaceutical industry, there's also somebody who worked for Monsanto there. Definitely not your usual random group of scientists and physicians. The second study is the Geisinger Health System study, and what they're doing here is using health records. It's in collaboration with the School of Public Health at Johns Hopkins. Essentially, this is rather like the descriptive epidemiology study I showed at first. They haven't got funding yet, or only a small proportion. They haven't even started yet. This could take a very long time to come out. This is the kind of mapping of their district, which is, and these are the wells, and the black are the wells which they are planning to build or are permitting. So again, their approach is descriptive and ecological, and it's got an imperfect overlay. It relies on physicians' ICD-9 coding. There's unsophisticated exposure modeling and incomplete health outcomes looked at, and funding is not yet available. I can tell you from my conversations with the NIEHS, they want to fund research which is well-designed epidemiology, and this is the only study which at the moment we know about is being funded, and unfortunately people don't publish their designs before they do their experiments, so this is all rumors, and I don't even know whether I should show something which is not really evidence, but what we can say is the University of Pennsylvania, Columbia, and Harvard are doing studies in this area. It's not comprehensive, they're really small different projects, and it's certainly going to be helpful and important, but it's not going to help. So we have a lot of gaps remaining on the second handout I've given you. These categories of gaps are all detailed, and I'm not going to go over them. I'll let you read them yourselves. What I want to say and to remind and underline, this is the biggest health challenge. Methane is a very potent greenhouse gas. It's leaking at every single point along the way in this procedure. It's about up to 105 times more potent over a 20-year period than other forms of fossil fuels, or carbon dioxide particularly, and we're finding that it's leaking even in the cities where we're consuming it at the moment. So finally, just to finish, do we have an alternative? We have all of this in the ground right now under our feet. At the moment, the spot price for natural gas is $4.07. That's not enough to make any money for the producers, so there's a proposal to build 19 giant export facilities for liquefied natural gas. This doesn't keep us energy independent if we're going to export it all. You may have heard that Japan is now jumping into this. They want to join the economic group of Pacific countries, and the carrot that is dangling in front of them is that they will be able to get natural gas. At the moment, the coal, which is not being used in fired stations in the US, is being exported and causing pollution in other countries, which are converting their gas generators to coal generators, believe it or not. But we have this study, which many of the co-authors are on the board of PSE, which came out very recently, just a month ago, in energy policy. It's multidisciplinary, and what it shows is that we are right here, right now, and that by 2030, the fossil fuel use, if we went by this plan, which is all wind, water, and sunshine based, in other words, completely renewable, we would be off fossil fuels. This can actually happen in New York State. This is based upon all the evidence that we need. The investment is not much greater than it would be for investing in the infrastructure in natural gas. I think we should go along this route. I think we should continue studying what's happening in other states. I trust that Nirav Shah, who I respect, he's a native of Buffalo. He went to Harvard for undergraduate. He went to Yale for medical school. He went to Yale for his MPH. He worked at Geisinger in research, and then he was a physician, an internist, and recently he redid his boards to get back to seeing patients. He's a wonderful person. He's new on the job. He's green around the edges. He's having to sort out Medicaid in New York and the Affordable Care Act. As I say, he knows what I've shown you today, that there really aren't any good, decent epidemiological studies. That's what he did his MPH in. He understands what the science of public health is. So I'm hopeful that he's going to be able to show some grit, and I hope that in a few weeks' time we will hear that we need to have these studies done, or we need to sponsor them in other states. Meanwhile, in New York State, we should move along with this plan. Thank you.
Like I said, we're very lucky to have this kind of talent in our city.